Yeah, okay, thank you. Good. Okay, so my name's Evelyn Weir, as Richard said, and I just want to say thank you very much for the invitation and the opportunity to come along here today. Richard got in touch with me about April-ish, maybe, to see if I would be interested in coming along, and I thought about it for 1 minute and then said definitely yes, because CMT has been an interest for me since I've been a student, and that wasn't yesterday. I don't know why it was an interest. I've got no story to tell you. And at that time, when we did podiatry, it was maybe one slide in one lecture of neurology. But there was just something about CMT that grabbed my interest. And from there on, and it's been a personal interest for me, but also very much a research interest, along with lots of other neurological conditions that affect the lower limb. So what I propose to do is, I'm going to go over some of the things that can happen in the lower limb with CMT, and I'm sure you'll know much more about that than I will. There is a reason for going over them again, and then I'm going to have a wee look at CMT over the life course, so to think what it's like for children, for adolescents, and then into adulthood, and then the non-pathological effects of CMT at the same time in ageing. And then I don't know how many of you just as interested have ever been to a podiatrist? Loads. That's great. Well, I can assure you that if I'd asked that question 10 years ago, I would have got a very different answer. So that's great that so many of you have been to see a podiatrist and you know what a podiatrist is and what a podiatrist does. For those of you who haven't, podiatrists look after all of the lower limb, not just your feet. And we train for a long time to look at the whole of the lower limb and look at lower limb disorders and so on. And then I'm going to finish with, I thought it might be helpful to give you a bit of a guide about how to look after your own feet, because a lot of the literature in CMT stops at the ankle. So a lot of the research literature looks at all the lower limb joints. Lots of research about the ankle, but then there's a lot of gaps in research about what actually happens in the foot in CMT, so that's what I'll be covering. So if I've misplonked it and that's not what you want to hear about, then please feel free to interrupt me and I'll try and change as I go along. Charcot, Marion tooth. I'm sure you've seen these pictures before. One shouldn't have a favourite, but mine is Charcot, without a doubt. I've already offered to Richard that if I do all right today and you ever want me back, my research interests are also Charcot, Mari and tooth, and I could talk from now until sunset on any of the three. But Charcot is my personal favourite, and clearly the most sartorially elegant there in that picture as well. So Charcot is, where do we start in the lower limb world with Charcot? We've got Charcot joints, we've got Charcot contributing to lots of other things to do with the lower limb. But we've also got this amazing quote from Charcot, which I think pretty much sums up for a lot of people that I've met the CMT experience. So what he's essentially saying is that the first thing is in recognition. So I had a tutor when I was a student that used to say, do you know, Evelyn, you're always drawn to the obscure conditions. You're always drawn to the unusual. Stop looking for zebras and look at horses. You're more likely to see a horse out there than you are to see a zebra. Fair enough. So I went back and I looked at diabetes and I looked at the things all the other podiatrists were looking at. But what I tried to get through to my students is, yeah, we'll see lots of horses. You need to know when you can see a zebra. Does that make sense? So it's the diagnosis. That is the best trump. And that's, look at the language that they use there. This is a long time ago. And still that stands today, I would say. The diagnosis for a lot of people is not necessarily using the phrase a relief, but it's an understanding, and people think, okay, now I know, now all of the things that make sense, all of the stuff that's gone on in the past, it all kind of makes sense. And that's just one of my favourite Charcot quotes. So this is CMT Awareness Month, is that right? It is September. So I noticed that my colleagues earlier have used some prestigious journals and high-level academic writing. Ladies and gentlemen, I bring you the Sun. And just for balance, that's the Express. And the thing that interests me from these two articles, but they're both within the last 10 days, the thing that interests me about both of those is they focus very much on the feet. So they focus on feet, lower limb function, and so on. And the key emerging theme seems to be, I didn't know what was wrong, I just knew that I was tripping up and there were problems with my feet. And that seems to be part of the awareness. So if nothing else, I've brought you some high caliber reference material. You'll know all this. I'll let you read, I'll assume you can read through it yourselves. You know all that. Yeah. The problem is, we run a podiatrics clinic, so we get children who come in, they tend to bring their parents as well. And if you read down that list, quite a few of those things are often the concern. And that's with the horses. But what separates the zebras, or CMT, is often the numbness and the tingling. But trying to get a child to put that into words is really, really difficult. And children can tolerate vast amounts of pain and not complain about it. We know that from literature across all kinds of spectrums. Children will put up with a lot, far more than we might as adults. So the child themselves might trip and fall, so do loads of children. I'm sure you've all heard of dyspraxia. Yeah, so commonly diagnosed dyspraxia, the child trips and falls, dyspraxia. They might have numbness or tingling in their limbs. Now that means different things to all of us. What my numbness is isn't necessarily what your numbness is or what your tingling is. In the same way, fatigue, what do we mean by that? It's more than tiredness, isn't it? It's not tiredness equals fatigue. Muscle fatigue, true muscle fatigue is very, very different. And this is where neurology sort of gripped me as a student. You might have a highly arched foot, or you might have a flat foot. Why does that work? Because if you look through lots of different medical conditions, say for example rheumatoid arthritis, there's such a thing as a typical foot. But when you get into neurology, there's no typical foot. Some look like that, some look like that. So how do we then look at some kind of universal management recommendation if everyone's feet are presenting in different ways? And again, as we've said, the child may complain of pain or may not complain of pain at all. Parents who bring their children to see us as podiatrists, they usually say, she walks funny. There's something about the way she walks funny. She trips a lot, she's clumsy, or there's something just not quite right. And then we might say, the child might say, oh, they're not great at running, or they might avoid sports. Might just, not necessarily that they'll say, I'm not good at it. They might go out of their way to avoid sports. And unfortunately, schools are still quite sports dominant, so sports is a big part of it. And if you're not good at sports, then that can have lots and lots of kind of ramifications for children as they grow up and develop. And the child's limbs might look a bit thinner, but to know a child's limbs look thinner, you have to have the experience to look at lots of child legs to recognise a thin one. Yeah, because children's legs are quite often quite thin. And it's where they're thin that's the critical point. One of my podiatry colleagues in Australia said, you know, CMT can be a challenge at the best of times, and adolescence can be a challenge at the best of times. And put the two together, and you've got a huge challenge for young people. And there's some recent research to say that adolescents with CMT sweat more, and that's interesting in terms of the autonomic nervous system and any involvement that might be in that. It's not that they sweat in a bad way or they smell worse, it's just that the volume of sweat is increased, and that has an implication for us as podiatrists in terms of palmar sweating in the hands and plantar sweating in the feet. Might be put down to being a sweaty adolescent, but again, it's about acknowledging all the things that make up the big picture. If they sweat more, maybe think CMT. Tiredness and fatigue. And then we've got the whole thing about school and how people cope within the school environment and function to maximise their own potential. So often adults with neurological disorders, and CMT in particular, will say, oh, I was rubbish at this when I was younger. I wasn't good at that. I just didn't do that. I said, I couldn't do that. I couldn't do. I wasn't able to. I couldn't do. So I didn't do. And so, in terms of lower limb problems, I'm not sure how much you know about lower limbs, so I brought one along. It's plastic. I'll get you back for your snakes. I was just saying earlier, I've got two phobias. One is flying, and the other is snakes. So you've brought me along to the hotel next to the airport, and then you've put up slides of snakes. So my heart rate is only just recovering. Anyway, this is your lower limb. not a lot of people really ever get a chance to see what it looks like. The big bone here, that's called your femur, and that plugs into your hip bone here, and that's the big, thick bone that goes down your thigh. Everybody knows what that's called. What's that one? Patella. Fantastic. So that's a floating bone. It's not a weight-bearing bone. Then we've got these two. These are plastic bones, just so don't worry about anything. And they're plastic, and that makes them much heavier than real bone, interestingly, because real bone's quite light. There we've got the tibia, fibula. So two bones in your knee to your ankle bit. You see what's happening here at the knee? It's a kind of flat surface, isn't it? So it's a flat bone and a flat bone. That's not ideal. The knee's not my favourite joint. And then here we've got the ankle. And then look here. What's all this? How many bones do we have in the feet? We've got, depends if you count two little bones that lurk underneath the big toe here, but we've got about 26 in each foot. So that's quite a lot. And what holds the bones together? That's a great word. Ligaments. So ligaments hold bone to bone. So if it wasn't for your ligaments, that would just be a bag of bones. It's ligaments that hold those together. And then on top of the ligaments, we've got muscles. And one of the, I'm sure you've heard of something called peroneal muscle atrophy, which is sometimes associated with term used a lot with CMT. And the peroneal muscles come from this bone here, which is the fibula, but we'll get back to that a wee bit later on. So if anybody wants to have, I don't know if that'll balance. It won't. That'll be me when I find out the hip score. So we shall, I'll leave that there if you want to have a look at it later. So, you've got three peroneal muscles, but one's called peroneal something, but it lives around the front instead, so it's a kind of a rogue. But the two that we're interested in are peroneus longus and peroneus brevis. So some genius called them that because peroneus longus is longer, and peroneus brevis is shorter, brevis, brevity meaning short. And they can be found on the outside here of your lower limb. But this is when it gets interesting. So, what do we know about muscles? Muscles can't move unless they have nerve involvement. So to make a muscle move, the nerve has to send a message to the muscle for the muscle to move. So we've got different kinds of nerves. We've got nerves which move muscle, but we've also got nerves which transfer things back from the skin back up into our brain so that we know that something's happened, so something's touched us. For some people, the nerves can become oversensitized. So for example, you're all wearing clothes at the moment. That's good. But if you were to feel every single bit of every piece of clothing that was touching you just now, you would become overwhelmed in a sensory way. So we learn to filter out what's important and what's not important. But it's also important that we have sensation, because we talk about in healthcare protective sensation. And that's about where you've got sensation for a reason. So if you touch something and it's too hot, you move away. If you touch something and it's hot and you can't feel it's hot, you maintain that contact and then you do damage. So that's why the neuropathy part of it is really important, because it's the neuropathy that sometimes can put the skin and the tissue under the skin at risk. Because if you can't feel it, then you can't move away from it. So this is the deep peroneal nerve, and it's important because we talk about peroneal muscle atrophy, but the deep peroneal nerve is the only nerve that supplies all of the muscles on the front of your leg, which makes your foot do that. So if you lift your ankle up, that's your deep peroneal nerve that's doing that. So although the muscles on the front are not the peroneals, it's the deep peroneal nerve that's doing that. So all the muscles in the front of your leg are supplied by the deep peroneal nerve, and the only muscles that the deep peroneal nerve supplies are the muscles on the front of your leg. That will become relevant later. We've got the superficial peroneal nerve, and the superficial peroneal nerve supplies the peroneal muscles. So that's the muscles that are on the outside of your leg. Now if we go back to that slide, That's the deep peroneal nerve. So that's, you can see there, all those muscles that are listed down the side there, they're the muscles that lift your ankle up. But if you look at the box inside, can you see where it says cutaneous distribution? Well, that's just a posh name for what bit of skin of your body gets its sensation from that nerve. And for some reason, my students always remember this, that the cleft of skin between your first and second toes is supplied by your deep peroneal nerve. Don't ask me why, but that's just how it's mapped out. So it's kind of unusual, because if you look again, superficial peroneal nerve, it supplies pretty much everything else in the green category there. So all the rest of it is supplied by the superficial peroneal nerve. So when you're having your lower limb checked for sensation, it's important that you check both of those. So we're not jabbing randomly around in the area. We're checking the area that's supplied by the superficial peroneal nerve, and we're also checking the area that's supplied down between the toes of the deep peroneal nerve. So these things are important when we think about sensory neuropathy. So between the deep peroneal and the superficial peroneal, they cover all of the top of your foot. And if you have neuropathy in those nerves, then you need to be careful about your footwear and how tight you tie your footwear and about your socks and things like that. But we'll get to that when we get to the advice bit. So there's the foot. I'll just let you gaze in wonder at this incredible piece of architecture. Good, eh? Yeah. So the foot is kind of like a loose bag of bones. So one of the words I don't like, and we try to discourage our students from using it, is normal. But when we're talking about changes in pathology, we usually use normal to describe what would be happening in an ideal world. So can we proceed with that as an okay word? So in normal walking, we would hit the ground with our heel. And then we don't know what we're going to be walking on. We're going to be walking on a downhill slope, an uphill slope, a side-to-side slope, I don't know what that's called. We could be walking on cobblestones, we could be walking on, in my house, a piece of Lego. You know, whatever's underneath your foot in an ideal world, your heel would strike the ground, and then all those loose little bones would come down slowly one by one and mould themselves to the ground. That's why we've not just got one long bone in our foot. That would be so much easier. But we need the foot to be a mobile adapter. We need it to adapt to the ground of what's underneath our feet. Kind of cough when you've got a microphone on.
I know, sorry.
That's all the little bones that are involved in the foot. But then if the foot was all soft and mobile, when we went to take our next step, that wouldn't work, would it? So what we want the foot to do in an ideal world is to go down, mold to the ground, but then turn itself into a lever so that it pushes off effectively and then moves on to the next step, and then it starts all over again. So our next foot strikes the ground with the heel, foot goes flat, toes off, and steps forward. In CMT, I'm sure you've heard the phrase foot drop or drop foot. And that's where it's not so much that the foot has dropped, it's more an inability of the foot to retain itself to a normal position. So if you have a wee look at your own foot, and if you can, put your foot in 90 degrees to your leg, so you're making an L shape. And in an ideal world, you would be able to lift that foot a further 10 degrees in an ideal world. So that's what we would call necessary for normal gait. So I got the last slot of the day, which is what speakers always dread. So that means I'm allowed to ask you questions. So if you've got a drop foot, or what's that going to do to that limb in comparison to the other limb? Is it going to make it longer or shorter? So it's going to make it longer. So you've given yourself a limb length difference there. So you've got a long leg and a short leg. Go for clinical tests and measure your legs, they'll probably measure the same. But functionally, when you're walking, you've got a long leg and a short leg. Yeah? Go back to what's normal and ideal. What part of the foot do we want the ground to be struck with? The heel. You're good, you're good. Better than most of our students. What happens with a drop foot? toes are going down first. Now, mostly that kind of foot presents in terms with neurological conditions. So neurological conditions often create a drop foot. People who are visually impaired sometimes elect to walk with a drop foot. So if you think about yourself, if you're walking in the dark, you don't necessarily confidently strike the ground. If you're in pitch blackness, you wouldn't necessarily go straight down with your heel. You almost kind of walk like a cat burglar, so you would put your forefoot down and then you would put your heel. But normally we would want the heel. So that's foot drop. What problems might you get with foot drop? So tripping. Definitely a lack of push-off. And parts of the foot in contact with the ground at times when they shouldn't be in contact with the ground. Okay, so what are you going to do for foot drop? What's the treatment? Because podiatric mechanics is simple. Pull it up. So how can we do this? How can we do that? We could do it in a number of ways. If the muscles that are at the front of the leg aren't pulling up anymore, then we could do what's called a tendon transfer and shift muscles to try to pull that up. That's a possibility. What's an easier possibility? Splint it in some way. So, although I told you that in an ideal world you would have your foot at 90 degrees to your leg and it would go up another 10 degrees, it's better to have a foot at 90 degrees to the leg than to have it as a drop foot. So we could use something like an ankle foot orthosis or something just to try and hold the foot in a 90-degree position. And at least that gets around the idea of you having two limbs of different functional lengths. And it also stops the problem of the foot dragging on the ground, as it were. Anything else you could do? Surgery. We could do surgery, yep. So we could do various types of surgery. We could do a triple arthrodesis where we would fuse the foot. Oh, an example at the front. So triple arthrodesis. Or we could do what's called an osteotomy, which is where you take a wee wedge out of a bone and then shut it back together again. Or we can do tendon transfer. Lots and lots of things can be done with the feet. To what we used to call, the old-fashioned word used to be to make the foot plantigrade, which just simply meant just make the foot parallel with the ground. And that was seen as a better way. What are the risks of doing that, though, of fusing all the bones in the foot and making the foot at 90 degrees to the leg? Because I've told you that the foot's made of lots of little bones. So you don't get that shock-absorbing type of thing that you get once you've had the triple arthrodesis. So like any surgery, it's always a compromise, isn't it? So you don't get that nice rolling down of all the bones. You get more of a thumping. Whereas with the ankle foot orthosis, it's doing the same as the triple arthrodesis, but it's doing it on the outside. So in some ways, there might be an argument for that being better. So if assuming you've only got one drop foot, that is, we've got one leg longer than the other. So what we then have to do is something called circumduction. So instead of walking sort of straight forward like that, people have to do something a bit like that. So they have to put their hips out and make their leg go in a bigger circle in order to make that foot a bit shorter, or the leg shorter. And we call this compensation. And compensation comes at a price, because we then alter our gait to try to not, but then we alter our gait and that requires a lot of muscular effort. One of the things that you saw this morning was what's called a gas analysis machine. That's when you put something on to monitor your breathing. And we know that when you're walking with CMT, then your energy consumption is significantly higher than someone who doesn't have CMT, which ultimately would, of course, contribute to fatigue. So toes don't clear the ground during swing phase. So swing phase, that's just when one leg swings past the other. Now, most of us will have a point in our walking cycle where we're only on one leg. So we'll be balanced on one leg and the other leg moves past the other leg. Elderly people, and sometimes in Parkinson's, it's much more of a shuffling kind of gait. But we're aiming for this swinging phase. Okay, I'm going to have a break. And you're going to tell me what you would do for that foot. was that?
Support the arch.
Okay, so we've got what's called a highly arched foot, or we use the technical term pes cavus just to mystify things as much as we possibly can. So we've got a highly arched foot. And what are the problems with a highly arched foot? Exactly, you should be a podiatrist. You're only hitting the ground in 3 really small places. So I've got a friend called Judith, and I've got wooden floors. When she comes to my house in her high heels, she leaves wee marks in my wooden floors. When she comes round in her wellies, she doesn't leave any marks in the wooden floors. And that's because pressure equals force over area. So our feet are the size they are for a reason, because we need all of that area to try to help diffuse the pressure. But when we've got a highly arched foot, we're reducing the surface area that's in contact with the ground. Therefore, we're only walking on certain bits of our foot. So what do we do? I'm going to take my watch off because I'm notorious for running over time, so I can see it. So we could increase the contact area of the foot. How could we do that? Yeah, simple. So we bring the ground up to meet the foot. If the foot's not going to go down to meet the ground, we'll bring the ground up to meet the foot. So it's not the same as putting in an arch support for a foot that's pronating or flattening or whatever the words people want to use. It's literally about filling the gap and increasing the contact area underneath. And that's often what we do, and try to just increase the weight-bearing area under the foot. And that can make a massive difference for people. It can also, what do you notice about the toes in a highly arched foot?
I give it a lot of toe room. We take toe.
Yeah, often if your foot's highly arched, then your toes will do a bit of that to try to grip and try to make the foot stable. So you get the highly arched foot and the toes like that. If you can address the pressure under the arch, like if you press on your own hand just behind those bones, you'll see your fingers will straighten out. So it's the same thing, it's simple principles. When did you last have your feet measured? There's lots of media campaigns about women wearing the wrong bra sizes, and I guess that's important. But I wish they would set up a campaign for people to say when you were 20 and you were a size 5, you might not be now. So go and have your feet checked, because if you look at that particular example, the key thing there in a highly arched foot length shortened. Yeah? So the more pointy the triangle, the more short the base. Triangle like that, big base. Arch of the foot like that, long foot. Arch of the foot like that, foot shortens. So if you haven't had your feet measured since you were at school, then it's worth going back and just getting your foot measured, because we have patients telling us that they've got a very slim foot when they've come in with something like a table tennis bat on the end of their legs, and their feet are now broad, but because when they were a child they had a slim foot, they think they've always got a slim foot, and vice versa. Okay? So measure your feet. And if you've got a highly arched foot and your toes are clawed, we'll get to that. That can create a real problem. Right, you're all really good at podiatry now. I could probably leave. But what are you going to do for this one? So that's not a highly arched foot. You don't need a degree in podiatry to tell me that. That's a flat foot. So what we want to do with that is to try to put something. Now that bit, the pointer's not working now. There it is. That bit there of the foot, that's not designed for weight bearing. That shouldn't be weight bearing. And when bits designed for weight bearing weight bear, they don't have enough soft tissue on top of them to protect them, and you often get tissue breakdown or ulceration, and that's what we're trying to protect and prevent. So what would we do for this type of foot? We would shove something in underneath the arch to try to support the arch. So while the treatment for a highly arched foot might look very similar to the treatment for a flat foot, they're completely different in terms of the mechanical advantage that they're trying to achieve, although they might look similar. And that confuses our students no end. They say, well, hang on a minute. A patient with a highly arched foot, and we've made them an insole with a big lump in the middle. We've got a patient with a flat foot, and we've made them an insole with a big lump in the middle. The solution is the same, but the problems are different in terms of mechanical principles. So back to my bugbear. CMT doesn't stop at the ankle. So you've all got bones beyond your ankle, and it's often those that cause the difficulties. So we've got what we call a hind foot, a midfoot, a forefoot, and toes. Often in CMT, toes can do a number of things. These are particular ones are called hammer toes. So hammer toes are very different from claw toes. If you have a wee look at your finger, so if you point out your first finger like that, and if you bend it at the joint that's nearest to your hand, okay, so that's essentially what a toe looks like. That's your hammer toe. So it's flexed there, and it's often, a hammer toe is an osseous deformity, so that means it's a bony deformity, so it's held in that position. So nothing in the world that you can buy in Boots is going to fix that hammer toe. The only thing that can fix a hammer toe is surgical correction, okay? So a hammer toe is a bony change. And what's going to happen, do you think, to a foot that's got a hammer toe? It rubs in your shoes, and the tops of your toes are not known for having a lot of fatty padding. So sometimes, again, that's us putting it at risk of ulceration or breakdown and so on. So hammer toes are a big risk. Claw toes, on the other hand, claw toes are caused by an overpull of the muscles on the underside of your foot. What do we know about the muscles on the top of your foot in CMT? They're not working so well to dorsiflex your foot or to pull your foot up. Now, whether you've got CMT or not, I'm sure you know muscles work in pairs. And muscles cannot push things, they can only pull. So we've got a group of muscles on the top of the foot which are pulling the foot up, and we've got a group of muscles on the underside of the foot which pull the foot down. But what happens over the life course, whether you've got CMT or not, in the battle between those, the ones that pull the foot and the toes down always win. So that's why we need to keep our toes mobile and keep the toes moving. And in CMT, because this one, the top muscles are already not functioning properly, then you can get quite excessive clawing of the toes where the toes are all clawed up. Now, unlike a hammer toe, you can do something about a claw toe. So that's where props and things and stretching that can have an effect. So be sure to find out if you have any toe conditions. We use the word deformity, which isn't a nice word, but if you've got any toe conditions, make sure you know which one it is before you try to treat it. You can get your feet out later if you want. I'm not proud. I'll have a look at everybody's toes, tell you what it is. So what do we do as podiatrists? Well, we work very much these days as part of multidisciplinary teams, which is great. And we're working towards doing more effective foot screening. So unfortunately, we tend to see people way down the line when a lot of the neurological and musculoskeletal changes have already taken place. When I was a student, again, that was in the 1980s, so that was quite a long time ago in the aerobics era, we used to go down schools and do foot screening, but that was slowly and surely phased out. It was us and the knit nurse, which is making me scratch my head now, I'm thinking about it, but we would go in at the same time as the knit nurse, and she would check for knits, and we would check for foot problems. And that's all stopped, and that's a great shame, because there are quite a number of rare conditions, CMT being a condition, that we can also discover when we look at people's feet. So that's a real shame. So at the moment, those of us in podiatry education are working hard to lobby to try to get that back in. It's almost like the dental model. So you have your feet screened every so often for a checkup. And that's particularly important when you have neuropathy. And it's particularly important if you get older, and it's even more important because you can have more than one thing wrong with you. That took me a while as a student to learn that. And if you've got coexisting diabetes, then that becomes even more important to do those things. So we can do all that. We can do identifying gait abnormalities. So that usually involves, those of you who've been to podiatrists, I'm sure you'll be familiar with walking up and down, and us looking at you walking up and down from various angles and trying to identify what what it is about your walk that makes it different, and how we can restore that back to normalcy as much as we possibly can. And then, because of the way we walk, the soles of our feet are fantastic structures, but the soft tissue often builds up skin problems. So some people will find they've got excessive build-ups of hard skin, or they get corns, or particularly in a pes cavus type foot, so the highly arched type foot, you might get, if it stays like that when it hits the ground, you might get corns underneath the ball of your foot, one underneath your big toe, underneath your fifth toe. Highly arched but flattens out a bit, then you might get lots of diffuse hard skin across the ball of your foot. And equally with flat foot, lots of other things can happen. You can get hard skin on the side of your toe or whatever. And we can then, from that, provide you with either an insole or an orthotic. People often ask what's the difference between an insole and an orthotic device. An insole is made to fit your shoe, and an orthotic device is made to fit your foot. So the insole goes in the shoe, and it's usually a simpler construction, so that might be the big lump to stop the highly arched foot, or it might be in the form of some sort of cutout. If you've got a big painful corn, we might make a little pad and cut that bit out just to try and redistribute the pressure a little bit if we can. And the last one is the one that makes us always least popular, which is footwear advice. So we'll give you advice on footwear. And that so much depends on foot type. So it's impossible to say the best kind of footwear is this, because that depends entirely on you as a person, so many other factors. You, what surfaces you're walking on, what your BMI is, all sorts of things can play a part in what would be the best kind of footwear for you. Ankle foot orthoses, the jury's out a little bit in the world of podiatry, and the role in CMT, are they beneficial, are they not? There's lots of research going on about that. So it'll be interesting to see what that yields for the future, because when we do any kind of research, there are ways that we do it. And one of the things we do is we put little markers. I don't know if any of you have been to have all this kind of stuff done, but we put little markers on you, on various joints, and we film you, and fantastic technology worth hundreds of thousands of pounds turns you into a stick man, and that tells us how you're walking and what joints are moving where and so on. And we can provide things to change that, to make it look what seems better for us. But that doesn't really matter, because it's your perception that matters, whether it works for you or not. And that's where the research is lacking a bit. So we can say, oh yeah, we can do this, and that definitely improves this angle at that joint. That doesn't really matter if it's not improving your own quality of life or your own perception of how it works.
Can I ask a question?
Yeah.
If you go back to the previous screen,
Yeah.
you said the provision of insoles or orthotic devices, you talked about build-up of callus and corns.
Yeah.
You said you would make a device to fit round the corn.
Yeah.
Would you not treat the corn as well?
Oh yeah, definitely. Yeah.
Oh, you would. So
Yeah.
you would.
Yeah. No, we would reduce the hard skin, we would denucleate the corn, but that's only going to be a temporary solution, because the stresses and forces that are producing the lesions in the first place are going to come back. So we can remove a corn, but contrary to popular belief, a corn doesn't have a root. It will keep reforming because the things that are there. So yeah, we will be able to reduce the calcium corn.
Are you moving away, or is the profession schools and everything else are moving towards this bariatric type of device for shoes?
Yes. Although we still very much are the area specialists in terms of removing corns and callus and wound debridement.
Yeah.
But in the past, we used to do what's called just cut and come again. So we would reduce the hard skin or take out the corn and then say, we'll see you again in 6 weeks. But now the profession has moved on to say, well, wouldn't it be better if we didn't see you in 6 weeks? Wouldn't it be better if we could put something in your shoe and see you in 12 weeks? Or wouldn't it be even better if we could put something in your shoe that the corn and the callus doesn't form at all? So it's looking much more at a kind of, why is the lesion there, rather than treat the symptoms, treat the cause, that sort of approach. So that's very much where we're at the moment. Foot checks in the past. These were the pre-war checks for flat feet. So they all lay in the bed, and then it was everybody up, and then we had a real, nope, not you, definitely not you, definitely not you. So things have moved on a bit since then. We just do it here as an individual now, and we wear blue. What we would do is first of all, we would be examine your feet, weight-bearing and non-weight bearing. I always like to look at my patients walking with and without footwear, because there's a temptation to only observe gait when someone takes their shoes off, but in the real world, you wear your shoes, so it's important that we look at you with both. And we take a good history, because that's important. It's other things that are in your lifestyle. It's your social, your occupational lifestyle. All these things are really important in terms of developing any sort of treatment plan. And then from that, we can provide any sort of orthotic devices if required, because not everyone requires them. And again, we can manage skin lesions, so we can reduce the callus, we can reduce corns, we can debride ulcers, we can pad around them, we can do all those sort of things. And also nail conditions, because if you've got your bunched up toes, then your nails often are in contact with the footwear in a way that they shouldn't be. And the body's response to repeated trauma is to make more of the tissue that's being traumatized. So people often find that their nails get thickened a bit. So again, it's about looking at trying to see how we can reduce the nail plate and things like that. Also in CMT, there's a bit of evidence that the skin and the peripheral aspects becomes a bit more dry. So it's about how to maintain that and how to, that's not something we can do something about, that's something that you can do something about in terms of the application of any sort of emollient cream on a regular basis. So we can give advice on how to, and that dryness can occur at a much younger age than you would expect. So as we get older, lots of people have dry skin on their feet and on their hands, but it can happen in CMT at a much earlier age and stage. So what advice would I give you then? Well, firstly, to look at your feet as often as possible. I know for some people that's not easy, especially to look at the soles of your foot. There are complicated things you can do with mirrors, but some of them are quite risky. But even if you've got someone that you can ask to look at the feet for you and have a wee look, because what we're going to ask you when we see things is how long has it been like that, and if you don't know it's there in the first place, then that can sometimes not be helpful in terms of diagnosis. Have your feet re-measured. So if you're, like I said before, if you wear a 5 and you think you're still a 5, just go and double check that you are a 5. Things change. Also, be careful where you buy your shoes from. A lot of the shoes that are in the high street shops are made in Indonesia and exotic places like that, and shoes are still made in the old-fashioned way on what's called a last, and they're made on that type of foot, which is a long, thin foot, whereas in Scotland, we've got small, square feet. So you need to make sure that you get a foot that's there to fit your foot type. If you go into a shoe shop and turn a shoe over, look at the sole of the foot and think to yourself, is that wide enough? Is that actually going to fit my foot? So in terms of peripheral neuropathy, the sensation might be affected because of the things we discussed in terms of the impact on the nerves. So the same advice would apply as we would pass on to people with diabetes or any other peripheral neuropathy or alcohol-related peripheral neuropathy or whatever, would be to avoid putting your feet near extremes of anything. So don't check your bath water before you put your feet in. So you can check that with a thermometer, or you can check it with your elbow. But just be careful, don't put your feet in front of the fire, don't throw snowballs and then put your hands into hot water. So what we're looking for is no extreme changes in temperature, that sort of idea. So keeping everything as constant as you can. If home corn remedies worked, then we wouldn't. So don't buy anything that says it's going to take away your corns or hard skin, because it will have an acid in it, which while is sometimes a good thing, and we do use it under controlled conditions, the acid has no way of knowing what's the nasty bit and what's the good bit. And unfortunately, most of the acids are water-loving, hydrophilic, and your skin's quite full of water. And it then spreads through and makes a big mess. So we would avoid the use of any kind of home remedies that you might be able to buy. And visit your podiatrist as regularly as you need to. For some people that might be once a year, for some people that might be every 4 weeks. It depends on the nature of what's wrong. Footwear. Check the inside of your footwear regularly. If you think your sensation is compromised, make sure you're looking inside your shoes and inside your slippers for any foreign objects. You'd be surprised how many times that does occur and causes wounds inside the foot. On that note, slippers. We do tend to advise people to wear things on their feet when they're at home rather than go about barefoot. I don't follow that advice. I can't stand anything on my feet when I'm at home in my house, but it is better to try to protect your feet where possible and to wear slippers. But as podiatrists, when we go out on home visits, we see some sites of slippers. So make sure your slippers are relatively new and that if they have a back on them, that the back is at the back of the heel and not trodden all down and so on. Because we heard a bit about falls earlier, but slippers are definitely, you know, in the array of suspects for falls, slippers are definitely in there. So make sure ideally, you know, your slipper should be as much like a shoe than it can be, rather than like a flip-flop. So try to get whatever you've been advised is the right shoe for your foot type, then your slipper should just be an indoor version of that. Keep your nails short and filed. Don't do the women's own thing of cutting a V in it. That's just nonsense. So keep it cut straight across and filed. And if you find it difficult to get down to cut your toenails, or you have problems with scoliosis, or indeed a lot of these things are assuming that you have upper limb ability to do all these things and hold instruments to do that. If you can't, then what to do is go to speak to your GP and see what they can suggest in terms of foot management. Because one of the things we are trying to do in podiatry is to provide more of a needs-based service rather than an age-based service. So rather than to say, oh, the day you turn 65, you're entitled to free foot care, what we're striving to do now is to say, well, that doesn't make any sense. It should be based on needs and ability to be able to look after your own feet or not. And sometimes we've got the advantage of being really close to your feet, plus we have the advantage of having tools that can measure your sensation in your feet. So we can put a number on it. So we can tell you this year your vibration perception threshold was this, or your sensory number was this in the neurasthesiometer. This year it's just the same, or this year it's worse, or whatever. So those things are important in terms of monitoring. And then the toe box of your shoe has to be big enough to accommodate your toes if there are any toe changes. So when you get to my age, unfortunately, the first thing you need to do when you wake up is go for a pee. But if you're not at that stage or past that stage, then the first thing you should do when you wake up is stretch your feet. Any front sleepers? Good. That's unusual. No front sleeper. Nobody that's going to tell me anyway. I will come and look in your windows. Well, with CMT, front sleeping is best avoided simply because it forces the foot into that drop position anyway. So side sleeping is good. Front sleeping, not good. If you are a front sleeper and you're just scared to put your hand up, then what we would do with you is we would get you to sleep in a t-shirt and sew a couple of tennis balls to the abdominal area so that when you roll over it's so uncomfortable you roll back. Seriously, that's what we do. We don't encourage front sleeping. So when you wake up, your ankle, it really annoys me if you go to a fitness class and people say rotate your ankles. Your ankles can't rotate, your ankles can only go up and down. The rotation takes place in other joints that are further down the foot. But when you wake up, the best thing you can do is just move your feet up and down. So pull them up as much as you can. So imagine you're trying to get the top of your foot to touch your shin. You're not going to do that. That's the movement you want to be trying. And then you want to be pushing down hard. So up and down and up and down. Then you can do the wee rotatey thing. And then the really important bit is the toes. So make sure you're stretching all your toes before you weight bear. So ankle up and down, foot round and round, toes clench and stretch, then you go to the toilet. I know, that wouldn't work for me either. And then this is one of my favourites for giving to people to improve the intrinsic musculature of their foot and to improve foot function, is to get a bottle of, well actually, I'm not a fan of caffeine drinks, but a can of Red Bull, you know, the tall thin can, that is an ideal shape. But I wouldn't like you to fund the caffeine industry, but a can of Red Bull is the perfect shape. Failing that, a bottle of water in the fridge feels even better. And keep it away from everything else in the fridge though if you're going to use it every day. And just roll, you can do it while you're watching your favourite television programme, just rolling it back and forward, and that moves loads and loads of muscles that we are so lazy in Scotland and in the West. We don't need to use these muscles. So they what we call atrophy, atrophy. So what we can do is we can keep them going by pushing forward the bottle of water. So that's another good thing to try to do to keep your feet fit. Stairs are generally not a good thing in CMT, but the bottom step's always good. So as you can see here, long, slow, static stretches, about 30 seconds. Stand with 2 feet on the step. Please don't do it on the top step and then sue me. Do it on the bottom step. Drop your heel down. Just let your body weight sink down into that heel. Hold it for about 30 seconds in reverse. For those of you who live in a bungalow, build something. Yeah. If you don't have to. So everybody always forgets about socks. You can get devices. We've got a place in Edinburgh, the Whistling Tortoise, which is just an incredible name for a shop. But and they stock all sorts of devices that you can buy to make life easier. So if your hands are a problem, then you can buy fantastic gadgets to help you put on your socks. Or if you find it difficult to bend down to get your socks on. People always forget about socks. About how much thought have you given your socks in recent weeks? Not a lot. So if you have peripheral neuropathy, you need to think about your socks, because your socks are the interface between, for most people, they're the interface between your foot and your shoe. And socks are kind of made the wrong way, we think, as podiatrists, because the seam's on the inside. So wear your socks inside out so that the seam isn't pressing on your feet along the tips of your toes, because if you take your socks off and you can see your socks where they've been, if you can see the mark around your leg where your socks have been, like a ridgy bit, or if you can see marks across your toes where your socks have been, then you've got the wrong socks. So either cut a V in the top bit, that there are some times when cutting a V is acceptable, and it is in the band of a set of socks, or wear your socks inside out so that you're not having that ridge across it. Make sure they fit your feet. Socks might start off a size 5 to 6, but once you've washed and tumble dried them several times, they might be a 3 or a 4. So socks are cheap enough, replace them. And natural materials, where possible, always useful. Footwear, well, again, it depends how able you are to get down to your feet and how able you are to use, to tie laces and things like that. I think Velcro is probably about, we call it the posh thing to close your shoes, a retaining medium. And I think the best one's Velcro, because you can adjust that quite easily, and also you can adjust that in terms of if your ankles swell or your feet swell up. Now, my best take-home tip, and if you'd forget everything else that I've said, do this. Go home tonight, get a couple of bits of A4 paper, or A3 if you're really giant, and stand on the paper and get someone to draw around your feet or draw around your own feet, and then get a pair of scissors and cut out those bits of paper. So what they represent is the surface area of the sole of your foot, okay? The next time you go to buy shoes, you might get some weird glances, but take those 2 bits of paper with you. And if the bit of paper doesn't fit into the shoe, don't buy the shoe. Because we see people with CMT squishing their feet and having lateral compression on their shoes. And in the past, I used to say, well, men's shoes are all right. Men's shoes are generally better. But there's a trend emerging at the moment where men are moving towards pointy shoes. So so even for men, try the cut round your foot and take it shoe shopping, a wee bit surreptitiously, and just slip the bit of paper into the shoe and see if it works. Natural materials again for shoe wear, and also because shock absorption is a bit of a problem in CMT, don't get something with a really thin sole that you can feel everything through. Get something that's got a thick cushioning sole, and make life easy for yourself. Conclusion, not bad. I've only got 3 minutes to go. So things have come a long way, but the basic principles remain the same. So the principles from way back, if the foot's arched, fill the gap. If the foot's flat, try to correct it. The principles still remain the same. We've got much better materials. We've got carbon fibre, we've got stuff for molecular memory, we've got stuff that bounces back like your memory foam mattresses. So that kind of technology has moved on. The things we use have changed a lot, but why we use them and the basic principles are much the same. But you can do a lot for your own foot health by maintaining and looking after your feet. We take our feet for granted pretty much, and it's often only when something goes wrong. And my granny used to say, to quote my granny, who was born in 1886, which again ties in with Charcot-Marie-Tooth. My granny used to say, if your feet's sore, you're all sore, which for the non-Scottish among us means that, you know, foot pain is a miserable type of pain. It's a bit like toothache, it's all consuming, and other people don't really understand what that foot pain can feel like and how it can be so debilitating and can influence everything, mood, all sorts of things. So looking after your feet is kind of key. So thanks for your attention, and I need to now go and check the Hib score, but I'm happy to take questions or thoughts or comments. Yep.
First of all, can I just thank you for a brilliant talk? That was fab.
Thank you. Thank you.
We've heard many podiatrists over the years, but I think that was not only instructive but humorous and actually made us think, and I've learned quite a few things from there, so that's
Well, that's
brilliant.
really kind. Thank you so much. It's a genuine interest of mine, so I'll come back.
Thank you.
If I'm invited.
Secondly, my son has had so many surgeries on his feet and they've all gone wrong. Not one has worked. Is there a reason why he's had all 10 claw toes straightened with the hooks, and all 10 have gone straight like that again? Is there a reason why that happened?
Has he got highly arched feet? Are his feet quite highly arched? Yeah, often it needs to be a two-step approach, really. The first thing that has to be done is the bones have to be aligned, but also what sometimes has to happen, which doesn't always get done, is the tendons have to be lengthened. So I don't know if you remember Zorro, when Zorro used to sign a Z on everything. And in tendons, if you cut a little Z in them, then that lets it lengthen a little bit. So sometimes the tendon lengthening works, but again, it depends on the age of your son and lots of other factors.
Yeah, we've go back to the house, an awful lot of people, including our daughter actually, report that toe straightening surgery
Just doesn't work.
just doesn't.
I just hear it so often.
But it goes back to the point that this gentleman made earlier about podiatry changing. It's about not just doing the thing. It's the same. It's exactly the same with bunion surgery. We've seen it in podiatry for years and years and years. Yeah, you can take the bunion away, but if you don't take away what caused the bunion in the first place, then the bunion will come back. And we see patients all the time, they say, oh, well, it was really good for a while, but now it's come back. And you think, well, that's because no one's addressed why it was there in the first place. You can physically take two structures and shove them together. But if the forces that pulled them apart or malaligned them are still there, then the body's going to conform to the point of least resistance and go back to the way it was.
Can I ask you, please, if I may, when did chiropodists become podiatrists?
That's a bit of a politically hot potato.
That's why I asked it.
Are we being recorded? Well, we're still the Society of Chiropodists and Podiatrists. It's about protection of title. So certainly I qualified in the late 80s, early 90s, and it was podiatry then. So round about then, to answer your question, round about then. That's another political hot potato. The answer to that is nothing, really. What you want to look for when you go to a podiatrist is both the terms chiropodist and podiatrist are, in theory, again, it's difficult for me to answer. You've hit a nerve. But really what you want to look for is that someone is health HCPC registered. So they can still be a chiropodist and be HCPC registered. It just probably means they trained before podiatry was the title of it. So, and that doesn't mean anything. So there's a thing called the Health and Care Professions Council, and that's where across the UK, all physios, occupational therapists, and so on, all professions allied to health really, are registered, and that's where we register, and that's where we can be struck off from if that's necessary. So I would strongly advise you, if you're going to see anyone about your lower limb health, to go to an HCPC registered physiotherapist or podiatrist, because that means that they've completed the recognised training that would allow them to work, for example, in the NHS or whatever.
So again, H what?
HCPC.
What does that stand for?
Health and Care Professions Council. It used to just be the HPC, but they brought in social work from England now, so it's Health and Care Professions Council.
One other question, Evelyn, is some people with different types of CMT have got quite thin, skinny feet.
Yep.
Particularly those, I think, with clawfoot and pes cavus. Others, like me, have got quite swollen feet and ankles
Yep.
for no apparent reason. Can you put a light on that?
Well, I guess that's where the bio and biomechanics comes in, because we're all very different. So there might be other things, you know, we're not just defining it by the CMT, there might be other things that are going on. Tend to find in males, particularly young males in CMT, you get the longer thin foot type for some reason. It really just depends on on a number of things, and often with swelling there's a circulatory element that might be coexisting with the CMT. So it'd be about looking at how that swelling behaves. Is it different at any particular time in the day? Is it there constantly? Does it pit, what we would call, does it pit or does it non-pit? And all those things would might play a part. Yep.
I'm fighting a constant battle with athlete's foot.
Oh,
My feet are the least athletic feet I've ever met. It's unfair, but I think it might be because they spend all their time in NHS boots and plastic boots.
yeah.
If I spend a day without spraying them, it sort of tries to come back,
Yeah.
and then it's a terrible job getting rid of it again.
Well, fungal infections are notoriously difficult to get rid of, whether they're on your skin or on your toenails. Fungal infections love damp, dark environments, so that's pretty much the inside of a shoe. There's a list of medicines that people with CMT are advised not to take. So some of them are never, and some of them are with caution. And on the probably best not list is something called griseofulvin, which is an old-fashioned drug for, don't write it down because you don't want to take it, for fungal infections. So you can treat fungal infections systemically with oral medicine, but that's not recommended in CMT. So you would be best to treat it topically, which means applying the fungal. And it really does require a lot of diligence and repeated applications, and also to treat the footwear as well as the feet. So you want to be rotate, what we try to suggest, and again it's really difficult. We don't have a solution for that, but just to try to rotate your shoe wear. So maybe you've only got the one pair. Well, go back and make a case to get another pair.
They gave me a second pair and they totally do not fit. They're
Right.
completely different shape, they don't fit.
Well, it's unreasonable. We would argue it's unreasonable. Have you got a podiatrist?
It's not the sort of podiatrist you were talking about.
Right.
I go to an orthotist.
Right. Well, they should be able to contact the shoe fitting service and ask them, because it's unreasonable.
Well, this time he drew around my feet because I more or less made him.
Right. Yeah. Well, that's unfortunate, because a key thing in managing fungal infection is rotating your shoes,
Yeah.
spraying your shoes and leaving them for 48, ideally 72 hours, and then going back to that particular shoe wear.
Well, I've only got one pair.
You've only
I
got
don't
one
have
pair.
that luxury.
No. I would just persevere with some of the topical antifungals that you can have. The other thing to do is get your podiatrist to find out what it is, because there are lots of different types of.
I've asked her and she just says keep using the Lamisil.
Yeah, but if she gets a mycology report, Lamisil is only effective against particular fungal infections. So if she takes a skin scraping and sends it to mycology, that's a bit of a tongue twister. Then they'll come back, and not only do they helpfully tell you what the fungal infection is, but they'll tell you what agents are effective against it. I wouldn't treat a fungal infection unless
I'll see what I can do.
see what you can do.
Thank you.
Oh my goodness, lots of questions.
Are you a practicing podiatrist?
Yes.
You are? Within the NHS or private?
No, privately.
Private.
I'm full.
You mentioned the jury was out the AFOs.
Yeah.
Can you share some of the for and against, just so an idea of
Yeah,
what that is?
Again, the problem with the for and against is that they're mostly looking at it from a clinician angle, so they're looking at it from a videoing people with and without. Sometimes they've been looking at the thing that I mentioned earlier called compensation. So with an ankle foot orthosis, so you've fixed the foot drop problem and you've got your foot 90 degrees to your leg, but what you're doing is you're making the bigger muscle groups work in a different way, so your quadriceps and your hamstrings are working in a different way because you've now got this 90-degree leg. So the most recent paper that I've seen, which was last month, was looking particularly in CMT at the benefits in gait of ankle. If anybody's interested, I mean, I don't just use the Sun for reference. I did actually use quite a lot of academic papers to put that together. But if anybody's interested, feel free to email me and I can send you. I know it's not easy if you're not in academic life to get hold of medical papers. Some of that, I find the genetic stuff quite impenetrable in terms of the academic papers, although I try. But a lot of the gait papers, if you leave aside the statistics, they're actually quite easy to read and make a lot of sense. And really what the research is saying is that when they compared the gait of with and without, there seemed to be no mechanical advantage. So what was alluded to this morning was something called a systematic review, and that's where you take lots of studies, put it together and do a systematic review, and that's what's lacking. Some sort of algorithm or protocol to decide who would benefit from an AFO and who wouldn't. So that's something that really, there are so many gaps in CMT research, unfortunately, but that's I would say that's one of the key ones, and indeed there's a priority paper came out recently, and it's down, I think, about the 4th or 5th priority to look at some kind of overarching approach to whether someone gets an AFO or they don't.
Could you ally that to physiotherapy?
What, sorry?
Could you, in
Sorry.
terms of research?
Oh yeah, I've already been
Well, Gita was.
I've already got some sort of deal going with Gita, some phone call on Wednesday, I think. But yeah, but no, that's part of her focus at the moment. So I think they're looking to I think they've got an orthotist, but they've got a gap for a podiatrist. So I think I may fill the gap. But yeah, that's what it's all about. It's about everybody all working together, and we all bring slightly different perspectives to it, but all working together for a common goal.
Well, thank you again, Evelyn.
Thank
It's
you.
been a fascinating afternoon.
Thank you.
I hope you learned a bit from the earlier part of the day. We've
did.
certainly learned a lot from you this afternoon.
I've
In a very
enjoyed
clear
it.
and succinct
I've
manner.
enjoyed it very much. If anyone knows the Hibs score, if they could just silently signal it to me now, that would be.
Gibbs losing our 1-0.
Yes.
Yes.
Thank you very
So
much.
thanks again.